Do you have a holding slide to share?
Okay, it's 5 o'clock, so I think we're ready to start. I'd like to welcome you all to this first webinar of the ENS spine section. Title of this webinar today is Controversies in Spinal Infections. What we have, or the format we would like to do this is have a case presented, and after this case presentation, hear pro and cons for a surgical or conservative therapy of a spinal infection. I'm going to present the case, and we hear about the conservative therapeutic options from Andreas Demetriadis from Edinburgh, and as a first step about the surgical options from John Duff from Lausanne. The case I picked is a case I used from time to time for education events, and I'm always surprised how different the opinions are about this case, and therefore I thought it might be a good case to discuss it in this setting, discuss it in the setting of a webinar, and to see what pros and cons for a surgical or conservative approach would be and what the controversies in this case would be. So let me share my screen and start with the case. Okay, this is the clinical data. We were talking about a 54-year-old female patient, and she had progressive lumbar pain since 3 months and therefore got an MRI. On examination, when she showed up with her MRI, she had an upper lumbar pain, no sensory motor deficit, so no neurological deficit at all. Comorbidities, she's obese with a BMI of 40. She's got an arterial hypertension and a diabetes type 2. And these are her images. This is a T1 non-contrast on the left side, T1 contrast on the right side, sagittal MRI. An axial MRI, T1 contrast, and a T2 sagittal on the right side. And we got a bone CT. This is her bone CT of the thoracolumbar junction or the L spine in the lower thoracic spine, showing the defect in L1 and L2. And her lab values, a C-reactive protein of 120 milligrams per liter and a normal white blood cell count. So this is the patient, this is the case. We're going to hear a surgical perspective on this case as a first step from John Duff, and then later on, a conservative perspective. And the way we handle it, please, when you have questions, when you have any of the speakers to the case, use the question and answer box, type in your question. I'm going to read this question out and we're going to discuss the points you want to make, the questions you have here within this webinar. Okay, that's the case. Now I'd like to invite John Duff to give his perspective on the case, to give his opinion, what aspects would speak for a surgical treatment of this spinal infection.
Okay. So thank you, Florian, and thanks for the introduction, and thank you to the organizers for the invitation to participate in this ENS spine section webinar. And yes, this is a highly discussable topic. So I'm going to look at the arguments in favor of surgical management. So if we start with the basic things here and what we need to know, the clinical characteristics that this can happen anywhere in the spine. Obviously, for the reason of number of levels, it's more frequent in the thoracic spine, less so in the lumbar spine, and even less so in the cervical spine, but it can happen anywhere. The symptoms and the signs are classically severe localized pain. So it's rarely a mild pain, it's often a severe pain. And characteristically, the pain is increased on percussion. So the patient can be exquisitely tender. And then they often have a high fever as well. Now, this can cause neurologic deficits, and there are a couple of mechanisms how this may happen. Direct decompression, either from an abscess mass in the spinal canal or from retropulsed bone fragments from bone destruction, or a combination of these. You can also have cord infarction from venous thrombophlebitis and venous infarction. And then you can have direct spread, rarely, but in advanced cases, that goes through the meninges and you get a myelitis, so a direct infection of the spinal cord itself. So all of these mechanisms can occur. So if we look at the source of infection, and in many cases now, there are many possibilities here, but frequently we see, a boil, a cutaneous boil or an infected hair follicle can cause this. It's commonly seen in intravenous drug users, so you need to be aware of that. And also in a vulnerable population, such as anybody who's immunocompromised for any reason, diabetes, for example, any transplant patient, renal failure, another one, alcoholic patients, and also elderly, frail patients. And the important thing is when you have a clinical suspicion, and it's very important that an unexplained back pain, you have a suspicion for this, the investigation of choice is MRI scan. And when you see on MRI that you have gadolinium enhancement centered on the disc space and on the cancellous bone, you can be pretty sure that this is very likely to be an infection. And this is in contrast to neoplastic lesions, where the contrast enhancement and the bony changes are centered on the vertebral body and not on the disc space. So neoplasms spare the disc space and infections attack the disc space by and large. It's not 100%, but it's commonly like that. On a CT scan, it's often very helpful to look at the bony changes. You can see end plate destruction typically, and you also can see paravertebral tissue swelling, as you see in the MRI scan also. And plain X-rays really have little role to play. Sometimes patients who come into the emergency departments, they get plain X-rays, and very often, even in the face of infection, even in the face of advanced infection, it's difficult to see bony changes in the first few weeks, so you can miss the diagnosis. The organisms that we find, Staph aureus is by far the predominant one. In 1/3 to 1/2 the cases, an organism is not identified. Strep is the next most common identified organism. And then you can have multi-organisms in about 10% of cases. And this is important when you have refractory treatment, refractory course to medical treatment. It's also important to remember that the mortality is non-negligible, anywhere between 4 and 31%. Now, obviously, the vulnerable and the elderly population are the patients who have the highest mortality. And the other thing that's important to remember is that patients who develop neurologic problems, the recovery is rare. So the prognosis for neurologic recovery is poor. And if you look at the overall management of these patients, and it varies geographically from country to country and geographic area and so on, but for anywhere from 10 to 25% of patients with this disease ultimately require surgery. So the majority are treated medically, and a certain amount are treated surgically. So what is the role of surgery? Well, diagnosis is one thing. So open biopsy is sometimes necessary. Blood cultures can give you an organism in about half the cases, and you can increase the yield up to about 60%. So even with an open biopsy, we often don't get an organism isolated. And if you look at this table here, this is the candidates for medical management of pyogenic spondylodiscitis. So if you have an organism that's identified, if it's sensitive to some of the antibiotics that we have, if it's a single space infection with little vertebral involvement, minimal to no neurological deficit, minimal to no spinal instability. So those are all of the factors that are in favor of medical treatment. So you could say that patients who don't fulfill these criteria are patients who are potentially surgical candidates. So let's look a little more closely with that. And then the other role of the surgical treatment, apart from diagnosis, is decompression of the neural elements and also stabilization. So those are two very important points for surgical management. So indication for surgery, failed medical management. So you have persistent symptoms, persistent severe back pain with empiric or with directed antibiotics, with persistently high C-reactive protein and ESR despite treatment. This is either under treatment or possibly misdirected treatment or a missed organism and so on and so forth. And this is an indication potentially for surgical intervention and debridement and further sampling of the infected tissue. The onset of neurologic deficit. So this is very important. You have to have a very low threshold for this. Even if the patient has a small epidural abscess, if there's any neurologic deficit, this is a surgical emergency. And it's also important to realize that once there is onset, particularly of significant or severe neurologic deficit, the recovery is often poor. Spinal instability. So if the patient has mechanical pain, so pain primarily when they stand up, relieved by lying down. If they have segmental deformity, particularly a progressive segmental deformity, that's an indication for surgery. And this is often in the face of extensive bone destruction, which is causing this instability. And then we've talked about a small epidural abscess where there's a relative indication for surgery, even with a neurologically normal patient, but a large epidural abscess is considered by many people to be an indication for surgery, even without neurologic deficit, because of the threat to neurologic function and the poor recovery afterwards. So what are the goals of surgery? Diagnosis, like we've talked about, to make sure that you're not missing a second organism. Debridement of the infected tissue, so reducing the load of bacteria and making the antibiotics more accessible to treat the infection. Decompression of the neural elements and spinal stabilization. So this is a paper that came out in 2013. It's a very nice review article by Alex Vaccaro's group. And they propose a management algorithm. And you can see here on the left-hand side of the screen, if you have a clinical suspicion of a spinal infection, you can do the routine blood test that you see. C-reactive protein is probably the most important one, blood cultures as well. White cell count is less valuable, as is the ESR. However, in these patients, they need MRI scans. So between the blood tests and between the MRI scan, like with the patient that Florian showed you, you can be pretty sure of the diagnosis based on radiology and based on blood findings. And then once you've made the diagnosis, if you look at the algorithm on the right side, this is a summary of the management, and essentially, again, neurological deficits and spinal instability, or both, or a patient who is septic and the infection is not controlled, are all candidates for surgery. So if we look at the surgical literature, so here's a summary of some of the results from about 2004 to 2012 that were published in the literature of surgical management of spondylodiscitis. And if you look at the first yellow column, many of the patients were operated for neurologic deficits. So not all of them, but many of them had neurologic deficits in these series. If you look at the next yellow column, the mortality is anywhere from 0 to 17%, I'm sorry, to 17%. So I think for the severity of the disease, I think the mortality is certainly acceptable within a surgical group of people who by definition would have more serious disease. And the neurologic improvement, despite about what I said, if you operate early enough, the neurologic improvement can be significant in these patients. And also the fusion rate. So if you look at the last column on the right-hand side, the fusion rate is also successful. So despite the fact that there's an infected field, you can get bony union in the long term in these patients. So if you put all this together, that the surgical management of these patients is an effective, or you could even argue a highly effective means to treat these patients. So if you, again, to summarize the main points, early surgical treatment for in the case of sepsis or for any neurological deficit, and early means, I would say, emergency surgery. Spinal instability would be considered, I think, an absolute indication for surgery. A relative indication for surgery for an epidural abscess without a neurological deficit, or for somebody who has poor pain control, where it could be a combination of the effect of the epidural abscess and a combination of the spinal instability together causing uncontrolled pain. So with regard to the aggressiveness of the surgery, in the older series, the vast majority of these patients were treated through a translaminar or a laminectomy approach. Nowadays, we do much more to treat this problem because the focus or the nidus of the infection is ventral. So anterior approaches, while they may be extensive or more aggressive, they're also highly effective. So you can mobilize the patients earlier, you get an improved correction of a deformity, and you get a faster fusion. So if you're going to do a surgery, you should think about doing a definitive surgery in these people rather than a half measure type of surgery. And the last point to remember, and there's a lot of literature on this now, that using metallic implants in an infected field is a safe practice to do and is a common practice to do. And this was 15, 20 years ago, the dogma was that you couldn't put any implants into an infected field. With modern antibiotherapy, we can do this now and it works well. So what are the poor outcome predictors? Well, typically, as you would imagine, age is one of the main ones. For reasons that are not clear to me, cervical and thoracic involvement seems to be a factor. Any chronic underlying disease, for example, diabetes, chronic heart disease, any neurologic dysfunction, so any paralysis of the lower extremities, any bowel or bladder dysfunction, delay in diagnosis, methicillin-resistant Staph aureus is also difficult to treat and has poor outcomes, and a delay in diagnosis, so a significant delay in the onset of symptoms and the definitive treatment is also a factor in poor outcome. So getting back to the case, so what would I do here? So you look at the pictures here, and clearly you can see the nidus of the infection is at the disc space here, I think L1, L2. And while there's a small component of epidural abscess, that's part of it there. But what you see on the CT scan is you see very extensive bone destruction. And I think I would say this patient certainly has some element of mechanical pain. And I think the likelihood of going on to develop a progressive deformity with the possibility of developing some neurologic symptoms is non-negligible. Now, she's had severe pain for 3 months. We don't have standing x-rays, so I'm not sure that she kyphoses. Her CRP is elevated. She has multiple comorbidities, including obesity. But I think there's an argument in favor of surgery, and this is what I would favor in this patient with the extent of bone destruction. So aside from doing the routine stuff, the blood cultures, potential percutaneous biopsy, either CT guided and antibiotic therapy, I think I would veer towards surgery here. And what I would do with this patient would be to do a left-sided retroperitoneal approach to the upper lumbar spine. I would do a double corpectomy for 2 reasons. Primarily, you want to have healthy bone above and below, and you want to debride the unhealthy infected bone. So by the time you do that, there's going to be little or nothing left of the body of L1 and L2. So having taken out the disc of 12-1 and the disc of 2-3, I would then put a titanium cage in, and I would close the retroperitoneal approach, and I would turn the patient over onto her front, and I would do a posterior percutaneous fixation through the back. And then while waiting for the definitive results, then postoperative empiric treatment using the mixture of antibiotics and rifampicin largely, to penetrate the biofilm that will inevitably form on the implants. So that's my argument in favor for this case, and I'd like now to hand over to Andreas so he can give us the argument for medical management. Thank you.
Well, thank you, John. Great overview. And now we hear Andreas for the conservative treatment.
So thank you, Florian, and thank you, John, for the invitation and for the great work you're doing in the spine section. Please let me know if this is okay to proceed.
Yes, good, it's visible.
Okay.
One thing, please. There are already some questions in the question and answer box. I'm going to collect those questions and we're going to discuss it later on. So whenever your questions come up, please type it in there. We collect those. Okay, sorry, Andreas.
Thank you, Florian. So yeah, there's a running joke that if you need the conservative argument, then ask someone from the UK. So here we are. And there's good reason for this, and we can debate this after the presentation. So what I'll do, I have no disclosures. What I'll do is I'll show you our experience from non-conservative and debate the pros and cons towards the end. So I have to acknowledge the data that John has provided are excellent, and I agree with everything. In my opinion, this is not a clear-cut case of conservative treatment because of the 3 points I am highlighting. First of all, the amount of the degree of vertebral body erosion is a lot, and it's at the thoracolumbar junction, and the patient has a high BMI, so we have a high risk of kyphotic biomechanical strain. So this is not the best case for conservative treatment. However, it is not wrong to do so, in my opinion. There is more information needed, and I know this is a way of we're going to stage this discussion. But of course, before any decisions are made, we need to know the result of any blood cultures, the result of any biopsy cultures. I would also add that we need some erect X-rays to assess for any instability or kyphotic deformity. We need to examine the CT better to assess whether the pedigals at L1 and L2 are intact, because that will also affect the length of the posterior construct. And of course, we need to initiate investigations into the source of the infection so this does not progress or recur. So I will share now lessons from 100 consecutive cases in Southeast Scotland, all spontaneous spondylodiscitis, or we can call it discitis, all treated non-surgically. And I have to acknowledge the input from Barry, who was a student with me, plus colleagues, Rebecca, Hugh, Sarah, and another Hugh from infectious diseases and virology. And the beauty of this is that they are not biased towards or against surgical treatment, and they can be more liberally critical of any results. And this is the way we approach this. We chose a short period of time, less than 3 years. So it's a curiously large number of spontaneous discitis within this period. It was retrospective, and this is the way we identified the records. And I'll share the details. Slight majority of males, average age of 66, with a very large range from 20 to 96. Only 19% were diabetic, another 19% chronic kidney disease, very small number with chronic liver disease, less than expected intravenous drug users, 8%, only 1 HIV, 4 hepatitis, and basically a few groups which are immunosuppressed, which were not the majority. The presenting features, as expected, 86%, the main presenting symptom was back pain. Not everybody had fever, about 60%, and then focal tenderness on palpation. 30 had some nerve root irritation signs, 22% lower limb weakness. 11% presented with retention, and there was a small subset of cervical cases that you can see, which explains the upper limb weakness. But the majority of cases, half of them, 49 out of 100, were lumbar. And the next highest number were in the thoracic region, as you can see on the right. Vertebral body involvement, almost everything. I can't explain why T1, 2, 3, 4, 5 were immune, if you like. I don't think there's anything behind that. And similar to our case, the CRP was high in all the cases, both at presentation and taking into account the peak. However, the white cell count wasn't necessarily very high. 67 patients did not have an elevated white cell at presentation, and only half of them, or just over half of them, had the white cell count above the normal range over the entire course of their admission. So just like in this case, the absence of an increased white cell count does not exclude the diagnosis of spondylodiscitis. Hence, the MRI should be ordered if this diagnosis is suspected. Remember, this MRI was done, but I imagine there may have been some resistance given the normal white cell count. So clearly the investigation of choice is an MRI, and initial findings, you can see in the bottom figure that discitis can come with other radiological features such as osteomyelitis, small paravertebral collections, small epidural collections, or large. Sometimes there is myositis, sometimes there is cord compromise, and sometimes, occasionally, about 10% of cases or so, facet joint septic arthritis. And that's one of the key situations where I would consider a more surgical approach. What is the burden of radiological surveillance? So here we look at the number of MRIs that were organized for our patients. Some of them had 2, some of them had 3, some of them had 4, which is a combination of clinical decision-making, but also flexibility in the absence of a specific protocol. And then if we ask ourselves, are the extra MRIs useful? Are they cost-effective? Well, 50 out of the 105 additional MRIs were routine post-treatment surveillance rather than clinical worsening. But in our opinion, only 17 of these were not clinically useful, and that the majority of these were useful in further management, because the further management may be maintenance of conservative management, but it's still a decision facilitated with a surveillance MRI. But we acknowledge the cost. As for the organisms, John already mentioned, most often the found is a Staph aureus, but here I can show you the other actual organisms that were grown. 61 cases had gram positives, 57% were only a single organism, and only 13 cases were a single gram negative organism. Very few anaerobes or mycobacterial. So gram positive, definitely the most commonly identified. Staph aureus, about half of the cases. E. coli, an eighth or so of the cases. We did not collect antimicrobial resistance data, but we did find MRSA strains in 8% of cases. So surgical procedures, but not treatment. In other words, diagnostic biopsy, and that included a CT-guided radiological biopsy or a surgical biopsy. And you can see here that no biopsy was done in 64% of cases. And that's admittedly strange, but that is what the data show. 15 out of 26 patients with no microbiological diagnosis also did not have a spinal biopsy, despite recommendations to go ahead with it. And the reasons for not doing that, of course, are reasonable. if we take into account patient frailty, no obvious focus to target a biopsy, or a location that was deemed not amenable to biopsy by the radiologist. How successful were the diagnostics? Causative organisms were identified in 74% of cases. 96% of cases of those, rather, were monomicrobial. 3 were polymicrobial. The diagnostic test which identified the organism was a blood culture in 70% of the cases. Spinal biopsy, only 20%. A combo of those two, 7%. And in very few cases, we did a 16S RNA PCR. So let's translate that into some numbers. Positive culture after biopsy, 20 out of 36 is only 56%, not high. How about those that already had antibiotics? Is a biopsy going to be useful? Well, here we can see that 11 out of 36, which is 31% of all biopsies, had antibiotics and yet allowed a positive culture. And if we only look at the positive biopsies, that's half of them. So it's still worthwhile performing a biopsy even after antibiotics have commenced. It's not ideal, but antibiotics may be necessary to have started. For example, in this case, in our series, 20 biopsies were done after antibiotics because of clinical need to start them due to sepsis, or the biopsy being taken whilst on therapy, guided by another result, such as blood culture, or indeed for good clinical suspicion. Now, the 16S PCR, 2 of them produced a causative pathogen. Both cases, the spinal biopsy had been negative, so it was useful. However, it does not offer susceptibility testing. It tells you the organism, but it doesn't tell you its sensitivities. And it's more expensive to do. What was the neurosurgical input? And this was a question that I let my microbiology colleagues assess because it was less biased. So they found that the neurosurgical input was variable. Only 18 patients were admitted to neurosurgery at some point. 6% had a assessment, in-person assessment, 40% telephone advice, 35% no documented neurosurgical input. And overall, 65% had some form of neurosurgery input, which also means that 35% of cases went ahead without us knowing of their status. Spinal brace. Only 35 patients had the brace. We are not sure how many were advised to have it, but 35 actually had it. The median duration was 72 days, with a range which was almost negligible to 6 months. Going through the notes, and that's one of the weaknesses of the retrospective reviews, is that whether the brace or not was used and its duration was highly inconsistent between patients, and there was no clearly documented reason why one was offered and one was not. But using a brace like a Jewett in extension to protect lordosis against kyphotic tendency is our preferred choice. Surgical treatment was offered in only 8 patients, 3 of which needed more than one procedure. And you can see at the bottom, 5 were abscess drainages, 2 were laminectomies, 2 were cage and plate insertions for C-spine, 1 for partial corpectomy, again C-spine, and 1 debridement. Now, of course, there are other patients who were treated surgically, but these were not in this consecutive series. So I'm only giving you this particular window in 2018. What can go wrong? I think we have to acknowledge that either the wrong decision or poor surveillance can lead to kyphotic deformity. which we can see here, inflection versus extension in the cervical spine. This arguably can be tolerated by the patient fairly well in the cervical spine. However, this is another case of an intravenous drug user who did not complete his treatment, did not attend regular follow-up, not necessarily his fault, because he had too many addresses, and I think some of the letters were misdirected, but this can be the outcome for which proponents of surgery might want to act earlier. How about antibiotics? I think it's pretty much accepted that it is a systemic treatment, usually IV. Our regime is initially IV for at least 4 weeks, often 6 weeks, then followed by another period of oral antibiotics. And effectively, it is often 6 weeks IV and 6 weeks oral. Majority received more than one regime. So more than one antibiotic in the regime, and about 25% to more than 2 even. In other words, 3. Floclox and Vanc are the most common. Sometimes there was changing between one to another regime because of the request to change to OPAT, and OPAT is a great service we have with outpatient antibiotic therapy, but it depends very much on the sensitivities. I won't bore you with what antibiotics were given, but it would be worthwhile for a second showing you why there was a switch from one antibiotic to a different regime. Often it's because we're switching from empirical to targeted after the sensitivities are available. That's about 18%. In 15% of cases, there was ineffective treatment with clinical deterioration whilst on antibiotics. And in another 15% of cases, an adverse reaction. And then 24 patients had to then change from the second to the third antibiotic regime, again, for a variety of reasons. A third, because they wanted to change to an oral system. A third, because of adverse reactions, and a quarter for clinical deterioration. Let's jump to the outcomes. We have found in this series of 100 patients that the hospital inpatient stay was quite long. Mean duration is 51 days. The range from 1 to 360. Of course, these were not in neurosurgery. They transferred to either infectious diseases or the referring hospital. But overall, these were long inpatient stays. We had a 15% mortality rate. 12 deaths were during index admission, and further 2 deaths within the year. Now, if we ask ourselves how many made a full functional recovery with no increase in care needs, only 58%. So the question I put to my colleagues here is 58, 60% good enough? How many had functional impairment? 27%, in other words, increased care needs. So again, the question is this good enough with conservative management, or is it the disease? 67%, is another important point, 67% have persisting pain after resolution or infection, and 8% had a relapse within 6 months. So the outcomes are definitely leaving room for improvement. Now, pain persistence is how patients will come back, and 67, in other words, 2/3, had pain after resolution of the infection. And this, I'm not sure whether it's his weakness of the treatment or reality of the disease. We'll touch on that in a bit. And in terms of, as I said already, death 15%, functional impairment 27%, complete recovery only 58%. So to summarize, non-surgical management is practiced widely, contrary to some people's opinions. It is effective, but it does carry caveats. In our series of 100 patients, unselected consecutive patients looked at retrospectively, there was a 15% mortality rate. There was a 58% full functional recovery, a 27% functional impairment, 67% persisting pain, 8% relapse. The question remains, is it suboptimal? In other words, is it a result of the disease or the treatment? Can we do better? And should we be thinking about prospective studies, randomized or not, between surgery and non-surgery? Going back to the case, I've already mentioned my concerns as to whether this is appropriate for conservative management. So my proposed plan would be to clarify the result of the biopsies and the antibiotics, to see how permissive the erect x-rays are, and if there is no dynamic instability, then I would propose initially conservative management with a duet brace, which holds the patient in lordosis for at least 12 weeks, but there has to be active surveillance. The patient would come back if he goes outpatient or OPAD, or if he has long line for outpatient intravenous dosage, or if he's still an inpatient. I would recommend serial erect radiographs, for example, at 2 weeks, at 6 weeks, and 10 weeks, and so on, while also surveying the CRP. And if there's any sign of failure, then I would intervene with a low threshold to an MIS, posterior only stabilization, but long. So thank you for your attention. And Mike, back to Florian.
Thank you, Andreas, for sharing this series with us and your view on the conservative therapy. I would like to show how we treated the case I showed you in the beginning, what we did, and tell you why we did so. So getting back, once again, I'd like to show some images here. You see the infection in the thoracolumbar junction, L1-2 infection, quite extensive infection, not only in the disc space, but extending to the vertebral bodies of L1 and L2 and creating this defect within the thoracolumbar junction. It's a patient, she's obese with a BMI of 40. It's a very biomechanically mobile or biomechanically stressed area. And I would be worried that this is already unstable. We do not have upright standing x-rays, but the reason doing this is the not limited spondylodiscitis and in the thoracolumbar junction, together with these comorbidities in the patient of obesity plus diabetes, that we decided to go for surgical treatment. So we did a staged surgical dorsoventral treatment. As initial step, a posterior fixation from T12, L1, L2, and L3. We placed short screws in L1 and L2 in order to get still have the opportunity for an anterior approach, open the spinal canal, get a biopsy. And as we decided early on that we're going to take this patient to surgery, we did not have CT guided biopsy or anything before the intraoperative biopsy. Then we went anterolateral approach, partial vertebral body resection and vertebral body replacement of L1 and L2, bringing in the distractable titanium cage. The diagnosis was that it's a Staphylococcus aureus infection, as most of those spondylodiscitis cases are. We did a full screening looking for an infectious focus, but this was negative. We couldn't find a focus, and in the whole spine MRI, no further spinal lesion was found. She was set on an antibiotic therapy, targeted therapy, and had 12 weeks of antibiotic therapy, 2 weeks IV, and then an oral antibiotic therapy, and had a resolution of her spondylodiscitis. This is how we treated it. And I think there are several points now we can discuss, and there are already several questions in the F&A box. And I'd like to encourage you, if you have more questions, bring your questions in so we can discuss it. Andreas, I would like some questions for you. You mentioned it yourself in the conservative series where you could show, yes, it does work conservative. There are some things which generate some doubts. I was surprised by the duration of hospitalization of these patients with 51 days. Why were they hospitalized that long? Is it because you can't mobilize them early enough? You get significant other complications? Is this a factor, having those patients so long in the hospital? Or is it just the antibiotic therapy, which you mentioned was done for 6 weeks IV in most of those patients? And whenever we have this discussion, usually we hear about 1 week, 2 weeks. How do you treat your patients concerning the IV period, John? And how could you comment on this once more? And what the mortality is concerned? 15% mortality is very high.
Thank you, Florian. So yes, I totally agree. Those are the questions which we as a group, but also we here in my center need to be asking ourselves if this is good enough. And the beauty of doing this from a different, with input from a different department, is that there is no selection. It was a consecutive series. If you had a disaster in 101 cases, or the month before, it wasn't visible. But if you had great successes afterwards, again, it wasn't visible. We just did 100. And amongst those 100, these are the results, which are suboptimal in my view. But I have to pay tribute to the quality of the service we get from microbiology. All decisions as to what antibiotics should be given and for how long are guided by the microbiology team. And also the facility of changing from an inpatient to an outpatient still on IV is excellent. And the OPAT, the outpatient antibiotic team, has revolutionized, I think, how short stay these patients need to put up with. And it depends on whether they can give an effective antibiotic regime that can be done as an outpatient. For example, usually nobody will go home before 2 weeks, because in the first 2 weeks they will have an IV regime that is a few times a day, and that cannot happen in the OPAT. In the OPAT, it will be ideal if they can switch to an antibiotic that can be given once a day. And that depends very much on the surveillance of the inflammatory markers and the advice of the microbiology, plus the compliance of the patient, plus the distance of where they live, and so on. To answer your question about the long stayers, I think the results are skewed by a subset of patients who cannot go home. One set of these, there weren't many, I think there were only 8 intravenous drug users who did not have a home. So you can't discharge them onto the street. And those are the ones who stay sometimes for weeks on end. Equally, if there are people who are elderly and live alone and they are not safe, they cannot go home. And finally, just to remind you that these patients don't stay in a neurosurgical bed. They will stay in the hospital. They will go back to either microbiology or the team that referred them to us, and that may be in a different hospital, because there is the underlying source of infection that needs to be investigated further and treated. So I think these are the factors which push towards the long stay, but it is a small subset that definitely skews the results.
John, you're on mute.
I think a factor that that you have to look at as well, which would be interesting, would be looking at the cost of, because this is a very prolonged treatment, multiple MRI scans, long hospitalizations, long follow-up, bracing, out of work, and so on and so forth. And I think there's, if you look at the economics of it, people say that surgery is overly expensive, and it certainly is in many cases. But here you have a situation where it's the expensive, the cost of treating somebody medically is probably exorbitant.
As is often the case with conservative measures, isn't it? Small charges, but for very long, whereas surgery can be acutely expensive, but then not so much to follow. Having said that, I think the MRI surveillance is necessary even if someone has had surgery for spondylodiscitis.
Okay, there's one question concerning this point in the F&A box, the Q&A box. It is, hi, when do you repeat MRI for those on conservative therapy? And I think this is as well a question for surgical therapy. And I would like to add, what would be your parameters you're looking for? What would you expect from a successful therapy to how this works on patient pain or lab values? What are your control parameters you use for the therapy?
John, you go first.
Okay. Well, I that's an interesting, because frankly, my bias would be not to do an MRI scan post-surgically. If the patient is doing well, certainly upright X-rays and, at some point a CT scan, but, between the artifacts that you have, and you have, parameters from, your CRP, your, resolution of back pain, your resolution of fever, and so on and so forth. I don't see a real value in doing a post-operative MRI scan, quite frankly. So my answer would be, unless I had a reason to do it, a clinical suspicion of another problem, I would not do MRI post-operatively. At
all? Not even in 6 months?
No.
3 months? None?
No.
Okay, your clinical endpoint would be normalized pain, a normalized C-reactive protein.
Yes, I think if the patient is, says their back pain is largely resolved. Now, these patients are rarely pain-free, but if they say it's significantly better than before, if your X-rays look good, and if your, the CRP and the ESR are normal, quite frankly, I think it's difficult to justify doing an MRI scan just to have a look.
There's another question concerning imaging. It's for PET-CT. Does any of you use PET-CT in the establishment of the diagnosis of a spondylodiscitis, or I think not during follow-up, as you don't use MRI, John? Does it play a role in the initial diagnosis?
In fact, in the initial diagnosis, I would say no, but certainly in the follow-up. Now, there's a rationale to doing that. And I think if you're concerned about focus of infection somewhere else in the body that may not have resolved, then I think an FDG, PET scan would be highly sensitive to look at that. So I think there's some rationale to doing that more than an MRI scan. But again, clinically, if the patient's doing well, I'm not so sure. But if there's some doubt, and if, for example, if you have a persistently high C-reactive protein, that makes more sense to me than doing an MRI scan after a surgery.
I don't deny that it's useful, but I can only comment that it's not easy to get or practical to get for this sort of situation. So I don't have experience of PET-CT for discitis per se.
That's a problem with the availability of PET scans. Not everybody has the option to get easily PET scans for those patients. Yeah,
no, but I think that would be a minority of patients. But if you had a particular concern, I think if you have access to it, I think it might be useful in a small number of patients.
Yeah. One thing that's worth commenting on the MRI question is we shouldn't do them too often, because there is a very distinct time lag in radiological changes compared to physiological or clinical changes. So the patient may be doing well, and the pain score may be coming down, and the CRP may be normalizing, but an MRI would still be strongly positive, but that's because it takes a long time for the radiological changes to take place. So I agree with John that the MRI request should be guided by clinical suspicion more than anything. They're not there to say, oh yeah, it's okay. So if there is suspicion, I think they should be done. But if the patient is doing well, they shouldn't be done. And therefore, one of the criticisms that I'm happy to take back to the local service is that it's not clear who was requesting these MRIs. And just to remind you that 35% of the patients were not even discussed with neurosurgery, but they were in the books.
Yeah, it'd be interesting if you could look back at these MRI scans and see, was there anything useful gleaned from looking at the images? And I would suspect the value looking back is probably minimal.
Yeah, I mean, if you go, I could see one good role for MRI surveillance if, let's say, I go conservative at the beginning in this case, but the patient reports increasing back pain and the CRP is also going up. Arguably, we could either do a CT to look at the possibility of increasing end plate destruction and deformity of the disc from within the disc space to the body, or an MRI for those two reasons. And that would be the reason to switch to surgery early. That's where I would see the role of a surveillance MRI, not as a pat on the shoulder kind of thing.
Yeah, no, I fully agree. I think MRI has an important role in a conservatively managed patient and has a far less important role in a post-operative patient.
Okay, getting to another point, we got many more questions. Getting to epidural abscesses. The question is, in an epidural abscess without neurological deficit, in which cases do you operate? And can you propose any clear criteria for or against surgery? I would like to add the point, how important are comorbidities of the patient? How important is the increase of C-reactive protein for the decision to operate in an epidural abscess?
Oh my goodness, there are many questions in that. Okay, so I'll start with the easy part. If it's a focal large abscess in a patient whose exam is clinically normal, I think there's a very good argument to doing surgery, because the threat of imminent neurologic injury is real, and the prognosis, if the patient does have an acute problem, is poor. So I think, and the literature points in that direction. You know, the real dilemma is, you know, what to do with a small abscess and what to do with an abscess that goes over 7 levels, or, you know, something that would require extensive surgery. And obviously, you know, I think we've all seen, if you've been in practice for a few years, everybody has seen an epidural abscess that's 6, 7, 8, 10 levels. And clearly doing, you know, a laminectomy over the entire range has a very high morbidity and probably isn't indicated. So, you know, I think, you know, getting back to the morbidity of if the patient particularly has comorbidities, if you have, again, a focal large abscess, I think the decision is easy. If you have a small abscess that's over many, many levels, then perhaps you can be more conservative with that. And then, you know, case by case in between, you know, is 3 levels okay? If it's a 40-year-old, you know, diabetic patient, but otherwise healthy, not so bad. If it's an 85-year-old frail person, then obviously you have that's going to sway you. But, you know, there's no black and white rule, but I think the important thing is that a normal neurologic examination doesn't eliminate surgery completely. Whereas, you know, obviously somebody with a deficit is a surgical case regardless.
Okay, there's a question regarding the risk of septic complications, or if a patient with spondylolischitis have a risk of septic complication, when is the right time to do surgery, to do stabilization? Or what I would like to rephrase it a bit. Well, what about the septic patients which comes in on pressors, in a bad condition? Is it a patient which needs stabilization or clinical stabilization first before you go for spine surgery? Would you start an antibiotic treatment? and then take him to secondary surgery, or is this a patient where you can gain some benefit from your surgical debridement in the treatment of his septic situation?
Yeah. Again, it's a clinical dilemma, but I think one of the reasons for urgent surgery is uncontrolled infection. If you have an infection with a large phlegmon in the paravertebral space, a big epidural abscess, that's just not going to be amenable to any quick antibiotic therapy. Sometimes, and the patient is septic, and I think it depends if the patient can be stabilized from an anesthesia standpoint or an intensive care standpoint. Then I think yes, there's absolutely a rationale to doing an emergency surgical debridement, which implies also a reconstruction at the time as frontline treatment for the infection. And this is the fulminant, uncontrollable infection with a life-threatening event, which is the sepsis. So yes, surgery does have a role to play in this. Obviously, if you can stabilize a patient to some degree over 24 hours with empiric antibiotic therapy, maybe, but I think you have to be ready to go and do these cases as a potentially life-saving surgery.
Okay.
Of course, we shouldn't assume that surgery is, we are surgeons, we like to operate, but every case has to be discussed with our anesthetist. If there's systemic risks that put our patient at higher morbidity risk, then we will try non-surgically at the very beginning, and with a threshold. If that's failing, then we may be able to intervene. But an unstable elderly patient with very high anesthetic risk, we need to also look at the morbidity risk of surgery. John, from the series review you have looked at, mortality risks or morbidity risk from surgery are also something to consider.
Yes, no, and there are series with 40% mortality, and these are classically the unstable elderly patients. So there's no doubt that this is a very precarious situation. And the cases where there's a fulminant, uncontrollable infection are certainly nowadays fewer and far between. But I think the message is that you shouldn't discount surgery on the basis that sometimes, despite this, and sometimes surgery is the way to control the infection. But these are rare situations, and obviously very far from ideal situations.
But overall, we're in a bit of a dilemma in the treatment of the balanced surgical conservative for spondylolisthesis patients, because we experience that those patients which need surgery the most means the old patient with a big infection, many comorbidities. They are the patients which are mostly harmed by surgery. And this is true for epidural abscesses, where we know that the older the patient gets, the more comorbidity has, the less likely is the likelihood that this is going to heal in the conservative therapy. But he's got the highest risk for surgery, and this is true for the other questions in spondylolisthesis as well. The 45-year-old who by chance got a spondylolisthesis, he's going to heal it, probably conservative, surgical. When you operate him, he's out of bed the day 2 after surgery. It's very fast, but he's on the other hand heal conservative as well. There's kind of a dilemma we're in, that the patient is mostly at harm, needs surgery probably at most. I would like to get back to the question of antibiotic therapy as one final point, as we already reached our time limit of 1 hour. Just to get to this point, Andreas, we spoke about, you said antibiotic therapy, 6 weeks IV. On the other hand, we have publications which shows us 1 week, maybe 2 weeks IV, 6 weeks overall. But I have to admit, I experience the same when I talk to my microbiologist. They tend to tell me or recommend a longer and longer duration of IV treatment. I don't understand on which data this is based. Do we have anything to argue for it, or is this just microbiologist's view?
Andreas, I'll allow you to take that one on.
Okay. I mean, there is a very good comment. I think it was Timo. I can't remember, but I think Timo made a good comment in the chat box that why give such high longevity antibiotics, which can be quite toxic, when we can results for oral. And I will share a screen, if you let me, again, with a trial that was published in the New England Journal of Medicine and asked the question, oral versus intravenous antibiotics for bone and joint infection. Now, it's not the traditional PDF view, but this is only 2019, so it's 2 years old. It's not specific for spine, but it is for bone and joint infection, which is what spondylolischitis is in group of. And the results supports the comments that we should be moving away from very long treatments. Oral antibiotic therapy was non-inferior to intravenous antibiotic therapy when used during the first 6 weeks for complex orthopedic infection. And this is worth reading. They definitely had a spine involvement in it. I can't remember the numbers, but I remember looking at it. I'm trying to find the figure. Sorry for making me dizzy. But there's definitely some spinal material in this, and I recommend watching it. Reading it. I'll try and look at it while you discuss something else. But I think we go entirely by what our microbiologists say. So if the microbiologists have reservations, just like we have a spectrum of surgical opinions, we have to allow microbiologists to have a spectrum of their own opinions. And some of them are more aggressive than others. But there is, I would say, increasing evidence that the 6 + 6 week periods can be reduced.
Okay, thank you. We see that there are a lot of questions, there are a lot of open questions. We still have questions in the Q&A box, which we're going to answer. But I'd like to finish this webinar now. I think we see this is a field of controversies, it's a field of unclear questions where we need more data, we need more trials. Andreas already suggested a randomized controlled trial for spondylolischitis, surgical versus conservative, which needs to be considered whether this is a doable trial or not. But this is we need more data to have a better discussion or more database discussion on this. I'd like to thank John Duff for his presentation, for the participation in this discussion. Thank you very much, John. I'd like to thank Andreas for his more conservative view on the things, and so all his discussion and arguments. And finally, I'd like to thank the ENS for putting this up, for organizing this. And I would like to thank you as the audience. We have 107 participants. We maximum had 119, so we lost only a small proportion, which I think is quite good. Thank you very much for spending your time with us, and have a nice evening. Bye-bye.
Thank you. Bye-bye.
Thank you, Florian. Thank you, John, and thank you, everyone.
Thank you. Bye-bye. Bye-bye, everyone.
In the background.